Thanks very much, Liz. So good morning, everybody. My name is Jenny Kurinczuk, as Liz introduced me, and I'm going to present the fourth of the findings from the Perinatal Confidential Inquiry, looking into the review of babies' deaths. So this section is focusing on the quality of local reviews and the findings in comparison with the findings from the confidential inquiry panels. So in addition to the confidential inquiry discussions and the checklist data, we were also able to use data from the actual perinatal mortality review tool results to more fully explore these issues. So just as a little reminder, a local review of care when babies die fulfills several purposes. The primary purposes being to provide information for bereaved parents about the quality of care, an assessment of whether different care may have prevented the death, and information for future pregnancy planning. And importantly, this provides an opportunity for any questions or concerns they may have about their care to be considered as part of the review. So it's important that parents are approached ahead of any review taking place, or certainly the review concluding, to ask if they have any questions or concerns they want to be considered. So that's the primary purpose. As an important secondary purpose, the reviews provide an opportunity for broader learning and identification of service quality improvements to improve care for future mothers and babies. So this was the first confidential inquiry that we've carried out since the introduction of the PMRT. And the deaths in this inquiry in 2019 occurred in the second year after the launch of the PMRT, which we regard as the sort of early consolidation phase. And most of the deaths, although not all, were reviewed using the PMRT. I'm going to just go through the key findings and then discuss these in a little more detail. So parent engagement is an absolutely key part of a local review of care. And we found that regardless of ethnicity, that no parents with identified language barriers communicated any questions or concerns about their care to the local review team. And we think this likely indicates the continuing theme of lack of available interpreter services, which was highlighted in the earlier presentations. So this was the second year following the launch of the PMRT, and at that stage, across all reviews, a substantial proportion of reviews in this inquiry, as with all reviews, were carried out either by a single professional or too few professionals of the correct clinical specialties to constitute a multidisciplinary review. And finally, the holistic grading of care of the mother and baby following review was not affected by ethnicity, but tended to be more positive than the grading reached by the confidential inquiry panels. So just to unpack those key findings a little further, not all parents have been informed that a local review of care would take place, but this was the same across the three different ethnic groups. The majority of parents either explicitly indicated they had no questions or concerns to raise, or they never communicated any questions or concerns. And except for one set of parents who sent positive comments, all parents with identified language barriers, regardless of ethnicity, didn't indicate they had any questions or concerns. So there was one set of parents who sent positive comments and nobody else sent any questions or concerns if they had an identified language barrier. So overall, about a third of parents of Black and white ethnicity asked questions or expressed concerns, compared with a sixth of parents of babies of Asian ethnicity. So fewer parents of babies of Asian ethnicity were raising questions and concerns. In terms of the quality of the reviews, only a small number of reviews were assessed by the inquiry panels as being of good quality, and the remainder were assessed as being poor quality, either in general, or they weren't multidisciplinary, or they did not address parents' questions or concerns. There was a slight difference between the ethnic groups, but it was very marginal, with reviews of white babies being of slightly poorer quality than the rest. Thinking about multidisciplinary review groups now, because this is a vitally important aspect of how reviews are carried out. So 13 reviews of the care of Asian babies, 11 reviews of the care of babies of Black ethnicity, and 7 reviews of the babies of white ethnicity were carried out by a review group which included less than 5 members. Now, the number of members of a review group is only an indicator of whether or not the group is multidisciplinary, but it is too few to meet the recommended standards for a multidisciplinary group. So the median number was about 6 overall, which means that a substantial proportion, over half, had a greater number of members. But again, the important thing is, who are those members? And a substantial proportion of all the reviews had external members present. But the ways in which the reviews were not multidisciplinary included reviews being carried out by a single professional, review panels which did not include an obstetrician, despite the fact that all these women received obstetric care, or at least pregnancy care. Review panels consisting only of midwives, care provided by 3 different hospitals, but the review was carried out by only one hospital. Although I would say this was before the function to transfer reviews to other hospitals was activated within the PMRT. And for a couple in particular, despite particular circumstances, a wider group of professionals with specific and essential expertise were not present at the review to actually assess the aspect of care. So, for example, mental health. So here is a vignette to illustrate the impact of not having a multidisciplinary review group and what effect it has on the local review quality. So this was a woman in her 3rd pregnancy. She referred herself at 23 weeks gestation with mild back pain and a mild pyrexia. On examination, she was 4 centimeters dilated with bulging membranes. And there was an initial plan for active intervention, and she was started on magnesium sulfate, antibiotics, and given steroids. And she was seen by a member of the neonatal team to discuss outcomes and what might happen after the baby's born. And that occurred the following day after admission. That day, she'd progressed to 8 centimeters and her membranes had ruptured, but she remained on labour ward for 4 further days with 2 consultant obstetric reviews every day, but no change in the plan of watchful waiting. And then her baby was confirmed as having died in utero at 24 weeks. She waited a long time for a confirmation scan, and following birth, she had a manual removal of placenta and a 2-litre postpartum hemorrhage. So the PMRT review was carried out by a panel of midwifery staff only. None of the parents' questions were directly addressed. They had sent questions in, they weren't directly addressed, and no specific issues relevant to the outcome were identified. The only learning point highlighted was that her reflexes were not tested 4 hourly when magnesium sulfate was being given, and the grading of care was given as B, care issues which would have made no difference to the outcome for the baby. The confidential inquiry panel had quite a different view about the care for this mother. There was a failure to discuss modifying the mother's plan of care during the 5 days she was on labour ward when her clinical circumstances were changing. Given the changes, it would have been appropriate to offer earlier birth when the baby was still alive. Her developing sepsis was poorly managed. She was in urinary retention and no evidence that her fluid balance was monitored or maintained appropriately. And there was no plan to scan the baby to obtain an estimated fetal weight to further inform the planning of care after the baby was born. And the panel concluded that the local PMRT review lacked insight as a consequence of a complex obstetric care being reviewed by midwifery staff only and reaching the wrong conclusions. And they failed to address the parents' questions, which actually highlighted the main issue relevant to the outcome of expediting the birth earlier. And this second vignette continues to highlight the importance of listening and responding to parents' questions and concerns about care. So this was a young white mother having her 2nd baby. She had a BMI of 41, complex social problems. She'd been referred for multi-agency and smoking cessation support. She'd missed several antenatal appointments in the early part of the pregnancy, but by the 3rd trimester, she was attending and her baby was identified as being on the 5th centile for growth, with the rate of growth decreasing. And a plan was made for induction of labour at 38 weeks. Sadly, a growth scan at 37+2 found that the baby had died. And following the birth, she did not receive any bereavement support or ongoing follow-up. And the parents questioned whether the baby should have been born earlier when the baby's growth started to decrease. So the local PMRT was carried out by several midwives and a paediatrician. This baby did not receive paediatric care, and there was no obstetrician present. And they didn't address the parents' questions, failed to review this aspect of care, which was expediting birth earlier when growth rate was falling off, which was the central issue to do with preventing the death. And the only issue with care identified that labour was not monitored on the partogram, and they graded the care as A. At follow-up, an incorrect cause of death was conveyed to the parents, and future pregnancy planning didn't include addressing her weight or other lifestyle issues. The inquiry panel concluded that the review was inadequate. There were no obstetricians present. It was an issue to do with management of growth, and had they followed national guidance to offer induction at 37 weeks, this may have affected the outcome for the baby. And this was the question that the parents had raised, and had they assessed their care against national guidance, they would have identified, with the parents' question, that there was an issue with care that was likely or was likely to have affected the outcome for the baby. Furthermore, had they not misinterpreted the post-mortem findings, more appropriate future pregnancy planning could have been provided. And they concluded that the lack of bereavement care, support or follow-up for this particular vulnerable woman was shocking. So, in summary, there was a slightly larger number of poor quality reviews carried out for babies of white ethnicity, although that was slightly marginal, but the ways in which they were poor quality was not particularly different between the groups, the different ethnic groups. Language barrier appeared to impact on parents' capacity to ask questions or raise concerns, and that's not surprising. Parents' need for interpretation services was identified in only half of the reviews where it was actually an issue, and a substantial proportion of reviews were carried out by single professionals or too few professionals on the panel to constitute a multidisciplinary review. So we have two recommendations relating to this part of the report. The first is to further develop existing PMRT guidance to ensure that all women's and parents' voices are actively sought and their questions addressed as part of the local review using the PMRT. And we in the PMRT team are working on that guidance and training, and I'll talk about that this afternoon. And the second recommendation is to ensure that all relevant staff in trusts and health boards have adequately resourced time in their work plans and contracted hours, and are supported to participate in local multidisciplinary reviews as external and internal members. And this is a continuing theme, and we know that having adequate time improves the quality of reviews, and that having adequate time is an issue in a number of trusts and health boards. Thank you very much for your attention.